Like to get started today. I'm going to talk to you about what's new in abdominal biopsy, and because of time, I'm not going to talk about new drainage techniques. Well, first choice we always have when we're doing a biopsy is do we do it under CT, do we do it under ultrasound? Well, there's certainly lots of ways of doing things, and I like this slide here. There's lots of ways of skinning a cat. So if in fact you want to get the job done, you get it done this way, that would be correct. So whatever I say is not necessarily correct. If you do something in a different fashion, then that's fine. So whatever it takes to get the job done. Well, the beauty of ultrasound, or now CT fluoroscopy, is we need no more blind needle placements. Well, this is sort of a comic slide. It does have a point. And what I do tell my residents or fellows, if in fact you do not see that needle, you have to stop. I've seen many problems arise where somebody does not see that needle, continues on, and then there is some sort of complication, perforation of a loop of bowel, or perhaps a bleeding complication. So the real beauty of ultrasound that we need to take advantage of is the ability to see the needle. Basically, we from UC Davis, and that's where I'm from, if we can see something in the abdomen, it usually can be biopsied or drained by ultrasound. Certainly there are a few exceptions there. Well, what are some of the principles that we use for better needle visualization? I call these ROC. We look at the angle and we look at color here. Just look at ultrasound physics. The needle shaft is best visualized when it is within the plane of the ultrasound scanner probe. And what we're trying to do is we try to put the needle parallel to the ultrasound plane, not perpendicular, when I do most of these procedures. What I'd like to try to do is put the needle exactly within the scan plane, such as this. But when I watch different people go ahead and do ultrasound biopsies for the first time, I often note they watch the screen to see where the needle is instead of seeing where the needle is in relationship to the transducer. So initially watch where that needle is in relationship to the transducer, or you'll be out of plane. If in fact you're out of plane, such as in this case here, and you do not see the entire length or shaft of the needle, you can rock the transducer back and forth until you visualize the needle. So what you want to do is rock the transducer in such a way that you can be parallel to the entire shaft of the needle. What this example shows is by rocking the transducer back and forth where we don't see the needle before in this water path, by just rocking the transducer, we can visualize the entire shaft of the needle. Another thing is look at that angle of the needle with the transducer. The more perpendicular the needle shaft is to the ultrasound beam, the better the needle visualization. Such as in this example, this would be ideal. We could potentially see the entire shaft. This, on the other hand, would not be as ideal, and we may not identify the entire shaft. We may identify the tip only. If we set up and we're going to go ahead and biopsy a lesion, and we think we should place the needle in this plane, remember we may not see that entire shaft in this plane. What we may want to do is think about a plane in which we could go ahead, switch the transducer into a more ideal plane, rock the transducer in such a way that needle is perpendicular to the ultrasound beam. Here's such an example that I'll show you in the right upper hand column, in which we're doing a thyroid biopsy, and we can see the entire shaft of the needle because the needle shaft is perpendicular to the ultrasound beam. A third thing that we can do is move the interstylet up and down. In this example here, you can see the needle placed in a water path. We take that interstylet up and down and move it. This takes 3 hands, and since most of us don't have 3 hands, we have to ask for either a resident, a fellow, or one of our sonographers to help us out, either to hold the transducer or hold the needle as we go up and down, as in this case for better needle visualization. probably the most helpful thing that I find is use of color flow. Color flow not only is helpful pre-biopsy or pre-aspiration to avoid vessels, but it is very helpful post-procedure, and I'll show you that later in examples. For each of these case analyses, just think, what am I going to use? CT, ultrasound, or what would I use? CT, ultrasound. What would be the approach to the needle path and the needle selection? For biopsies, we can do FNA, we can do core, or we may be able to do combined FNA plus core. Why would we want to do FNA? Well, what I do, for instance, for thyroid biopsies, I do what is called a 5-minute thyroid biopsy. I sort of have a rule because patients have a lot of discomfort with this if, in fact, you take a long time. So what I try to do is go ahead, tell the patients I'm going to go ahead, do 4 to 5 passes. I will be done in 5 minutes. We'll stop. My old plan of attack was I would do 2 biopsies. I would stop. I had a cytopathology tech there. I would ask him, is my specimen adequate? I always got the same answer back. Yes, it's pretty good, doctor, but we would like more. And after number 3, guess what the answer would be? We liked more. So finally, I learned after doing many of these, I'd go ahead and do 4 or 5 within a 4 to 5 minute time and then stop after that time. Well, let's look at biopsy for either cytology or histology and then consider FNA. Well, we'll consider FNA when we know we have a primary. For instance, we're doing a biopsy in the liver. We know the patient has colon cancer. When there is possible infection, or even for lymphoma, but we have to do flow cytometry, and in combination with core. Let's take a couple of examples. 68-year-old female with breast cancer, question Mets. In this case, you can see that there's a very small lesion in the left lobe of the liver. There's a couple of them. It ended up, we could see these under ultrasound as we see here, but these are less than 1 centimeter. In each of these cases, imagine you could do them under CT fluoro, but it may be very difficult to see. And in this case, I went ahead and I'm going to do this under ultrasound. Again, color flow pre-biopsy. That's about my biopsy path. But with color flow, I see the portal vein would be in the way. Well, I'm going to do a coaxial placement in this case. So I'll place a 17 gauge needle first, and through that I'll go ahead and do a 22. It would give me the option later to place a core needle, or in this case I could go ahead and place a 20 gauge if I knew I was doing only FNA or a 19 and do multiple 22 needle passes through that. This case shows me as I go in with the needle here, and I'm going to go ahead and do multiple needle passes again using a coaxial technique. And I've gone ahead and done that. Another case, very similar, 63-year-old with lung cancer, question Mets. Very small lesions or nodes around the periportal region. These nodes are again less than 1 centimeter. Again, in this case, I see this with ultrasound. I'm going to do a coaxial technique. I am not afraid to go through the liver, especially when I do color flow and I see no large vessels in my needle path. In this case, I place my needle adjacent to the node with the coaxial technique, and then I go ahead and I do multiple FNAs into this lesion. Again, remembering this is less than 1 centimeter. Diagnosis here was metastatic lung cancer to these nodes. Finally, when will I do core? Well, there's a whole host of different reasons. For instance, if somebody's failed with FNA or I failed with FNA. For lymphomas, it may be very helpful. More so for HCC than RCC. We do a lot of biopsies for potential renal cell carcinomas, and we found that FNA is helpful, but core is also good. However, for hepatomas in the liver, core is much more helpful than FNA. If we have an unknown primary, or we're going to go ahead and do a random biopsy, or we suspect a potential benign lesion. What sort of needle or core biopsy gun would we use? You can pick what you want to do. At our institution, often cost really trumps everything. So we may decide that we like one type of biopsy device, but because of cost, we go ahead and we select another type of biopsy device, which will work very well.